Are you constantly struggling to function because of last night? Are you just a night owl, or is your body actively sabotaging your rest? We all toss and turn sometimes, but learning how to tell if you have insomnia is the critical first step before a bad night turns into a chronic condition that threatens your health. We're diving into the surprising science of sleep deprivation.
That's right. And you shared some great sources detailing everything from, the symptoms and causes of insomnia to the often surprising treatment pathways. So our mission today is to really cut through the confusion. We're going to give you the precise checklist for chronic symptoms and zero in on the single most effective long-term solution, which, spoiler alert, is drug-free.
It's such a huge problem because occasional sleeplessness is almost universal, isn't it? I mean, the sources say up to 1 in 2 people experience some sort of sleep disturbance, and over 60% might have a restless night now and then.
Yeah, very common.
But when it becomes chronic, affecting nearly, 3 in 10 U.S. adults, that's when it stops being just an inconvenience and really starts being a health threat.
Exactly. Chronic sleep loss doesn't just make you grumpy. It's linked to serious long-term implications like heart disease, hypertension, diabetes, even depression.
Okay, so let's start with the basics then. What is insomnia, officially?
Well, at its core, insomnia is a persistent sleep disorder. It involves difficulty falling asleep, staying asleep, or often both. The key differentiator, though, for a diagnosis is that this has to be an ongoing problem that directly impacts your daytime functioning,
Right.
meaning it results in consequences like extreme sleepiness during the day or trouble concentrating, that kind of thing.
Right, okay. And you mentioned duration is crucial for classification.
Yes. There's acute insomnia that's usually short-lived lasting days or maybe weeks, generally triggered by something specific, like a stressful event or some recent trauma.
Okay, short term.
But we are really focusing today on chronic insomnia,
Right.
and that's defined by difficulty sleeping 3 or more nights a week for a minimum of 3 consecutive months.
3 nights a week, 3 months. Got it.
And what's kind of fascinating here is that chronic insomnia is often characterized by struggling to sleep despite having plenty of time set aside and the right environment, a dark, quiet room.
So it's not just because your bedroom is noisy or bright.
Right. Less than 10% of adults meet these specific criteria, but for those who do, it's more of an intrinsic problem, not just, say, a chaotic schedule. And we really need to emphasize this. Even if you clock 8 hours in bed, if that sleep is poor quality and you still wake up feeling unrested and impaired, you can still meet the criteria for insomnia. It's really about the quality, not just the quantity.
That distinction quality versus just the number of hours, that feels really important. And speaking of how the difficulties show up, our sources talk about 3 different flavors of insomnia based on timing.
Exactly. So first, there's initial or sleep onset insomnia. That's the classic scenario. You lie down ready for sleep and just can't fall asleep, takes forever. Second, there's middle or maintenance insomnia. This is where you wake up midnight, maybe multiple times, but you do manage to fall back asleep eventually. And this is surprisingly the most common form. Affects almost 2/3 of insomnia sufferers.
2/3. I wonder why maintenance insomnia is the most common. Is it because those mid-sleep wake-ups are often triggered by, underlying physical things that get worse later in the night?
That's a big part of it precisely. That midnight waiting is often related to those underlying issues we'll get into, like pain flaring up, maybe acid reflux peaking, or needing the bathroom, things like that.
Makes sense. And the third type?
That's late or early waking insomnia. You wake up hours before you plan to, maybe 4 or 5 a.m., and you just cannot get back to sleep. And this often leaves people feeling the most fatigued the next day.
Okay, so initial, middle, and late. Got it. And beyond the timing, we also classify it by cause, right? Primary versus secondary.
Yes. Primary insomnia is kind of that rare bird that exists on its own, without a direct identifiable external cause or another health condition driving it.
Less common, you said.
Much less common.
Yeah.
Far more frequent is secondary or comorbid insomnia. And here, the sleep problem is actually a symptom resulting from another underlying health issue or medication or substance use.
Okay, let's really unpack this for the listener who might be trying to figure this out.
Yeah.
If you're tracking symptoms, what specifically makes a bad night of sleep rise to the level of clinical insomnia? Let's start with the struggles you face, once the lights are out.
Right. The nighttime struggles, they're persistent and repetitive. So to be on the checklist, you consistently, 1, take a long time to fall asleep, that initial type. 2, wake up frequently during the night, that's the middle type. 3, struggle to fall back asleep after waking up, also middle or could be late. 4, wake up far too early and just can't get back to sleep, the late type. Or 5, spend a significant portion of the night just actively worrying, lying there stressed.
Okay, those are the nighttime signs. But the real diagnostic punch, you said, is the aftermath, the functional consequences that show how it's actually impacting your life.
Exactly, that's crucial. These include feeling exhausted, fatigued, or just generally unwell all day long. You'll likely notice difficulty concentrating, focusing, maybe having persistent memory problems.
Yeah.
Functionally, this often results in reduced motivation, poorer decision-making at work or with tasks, and slower reflexes, which, as we know, is incredibly dangerous if you're driving or operating machinery.
Yeah, definitely.
And we can't forget the emotional side either. Mood disturbances like
Yeah.
increased irritability, maybe generalized anxiety, or even symptoms of depression are hallmarks of chronic sleep deprivation.
Okay, so let's just recap that critical diagnostic criteria one more time.
Sure. The sleep problem itself, difficulty falling asleep, staying asleep, or waking too early, causes significant distress or impairment in your daily life. It occurs despite having a safe, dark, comfortable environment and enough opportunity for sleep. And crucially, it happens at least 3 times a week for a minimum of 3 months to be considered chronic.
3 times a week, 3 months, impacts your day.
Got it. Okay, here's where it gets, as you said, really interesting. Since most insomnia is secondary, we have to talk about the underlying medical and mental health causes. Because if we can solve the root issue, maybe the sleep often follows.
Absolutely. That's often the primary goal. Insomnia is commonly a symptom of chronic pain disorders. Think migraines, arthritis, anything that prevents you from getting into or staying in a deep, sustained sleep stage. It's also often linked to gastrointestinal disorders like acid reflux, breathing problems such as asthma or maybe undiagnosed sleep apnea, and hormone imbalances like those tied to hyperthyroidism or menopause. Neurological disorders too, like Parkinson's or Alzheimer's.
That makes perfect sense. I mean, if your body is literally hurting or struggling to breathe, your brain isn't going to just let you stay deeply asleep, is it?
Not likely, no.
But let's talk about the mental health connection. You mentioned it's often a two-way street. Yeah, and it's often the cycle that is the most insidious, the most difficult part of chronic insomnia. Mental health issues like generalized anxiety, depression, PTSD, they frequently trigger insomnia in the first place. But then once you are sleep deprived, your brain's ability to manage stress and regulate mood decreases significantly.
So the lack of sleep makes the anxiety or depression worse.
Exactly. Which then, in turn, makes it even harder to sleep the next night. It's a vicious cycle. Our sources mention about half of people with chronic insomnia also have at least one other mental health condition. The connection is really undeniable.
Wow, half. Okay, so beyond serious medical or mental health issues, what about the factors maybe more within our control? The lifestyle and environmental contributors? The things that might feed into primary insomnia or just make secondary worse?
Right, we absolutely have to look at substances first. Caffeine, obviously,
Right.
nicotine, and alcohol. Alcohol is a particularly deceptive one.
How so? People think it helps them sleep.
It might help you fall asleep faster, sure, but it severely fragments and interferes with the deep, restful stages of sleep later in the night. It virtually guarantees you'll wake up a few hours later, often unable to return to rest. So it disrupts sleep quality dramatically.
Okay, good to know. And certain medications too?
Yes, it's actually quite shocking how many common drugs can interfere, including some used for allergies, colds, blood pressure meds, even certain antidepressants like SSRIs can disrupt sleep architecture for some people.
Worth checking with your doctor if you suspect that. What about sleep hygiene? That term comes up a lot.
Yeah, poor sleep hygiene is basically about bad habits around sleep. Things like having a really inconsistent schedule, shift work, jet lag are extreme examples, but even just irregular bedtimes count.
Hmm.
It's also using your bed for things other than sleep or sex, watching TV, working on a laptop, eating. That forces your brain to associate the bed with wakefulness, worry, or entertainment, not rest.
Right. Trains your brain the wrong way.
Exactly. And too much bright light or blue light from screens close to bedtime is a huge contributor now. It suppresses melatonin production, essentially tricking your brain into thinking it's still daytime when it should be winding down.
Okay. Let's look at who is most at risk. The sources mention age as a factor.
Yes, sleep architecture naturally changes as we get older, making sustained sleep sometimes more difficult. Older adults are more likely to experience issues.
And gender also matters. Women are affected more than men. Why is that hormonal link so powerful?
Well, the key mechanism seems to be those significant hormonal shifts. Sleep quality can change dramatically during menstruation, pregnancy, and especially around menopause. It's due to fluctuating levels of estrogen and progesterone, which directly affect neurotransmitters involved in sleep, and also things like body temperature regulation, which is critical for falling and staying asleep.
And speaking of pregnancy, the numbers there were really striking. Almost 1 in 2 pregnant people experience symptoms, rising to 80% by the third trimester.
It's a massive jump, yes. Beyond the direct hormonal effects, there's increasing physical discomfort.
Hmm.
You know, difficulty finding a comfortable position, heartburn becomes more common, frequent urination, it all adds up.
And there were other risk factors mentioned too. Ethnicity.
Yes, the sources note that unfortunately, Black people tend to have higher reported rates of sleep disorders, including insomnia. This is often linked to complex factors, including higher levels of chronic stress stemming from systemic inequities, and potentially lower access to diagnostic resources or culturally competent care. It's an important area of ongoing research.
Okay. And inactivity.
Yes, being physically inactive is another major risk factor we see across the board. Regular exercise generally promotes better sleep, though timing matters.
Right. So if you're listening and checking off these boxes feeling like this might be you,
Yeah.
the first critical step is getting a proper diagnosis. What does that process look like once you finally go see your primary care physician?
Well, it usually starts with ruling out those potential underlying causes we just discussed. So they'll take a full medical history, ask about all your medications, supplements, conduct a physical exam to check for things like thyroid problems, for example. And they will almost definitely ask you to keep a detailed sleep diary for a week or two,
Who does that involve?
tracking exactly when you go to bed, when you think you fall asleep, when you wake up during the night, when you get out of bed for the day, and also how you feel during the day, tired, alert, groggy. It gives a baseline picture.
Okay. And if they need to dig deeper than the diary, that's when specialized monitoring comes in. What are the doctor's tools for diagnosis then?
The two main tools are, first, the overnight sleep study or polysomnography. That's typically done in a sleep lab, monitoring your brain activity, EEG, breathing, heart rate, eye movement, and body movement. It's really good for ruling out complex issues like sleep apnea or periodic limb movement disorder.
Okay, the full lab experience.
Yeah.
And the other one?
The other is actigraphy. This is much simpler in practice. You wear a small device, usually looks like a watch, typically on your wrist, for maybe 1 to 2 weeks. Its main purpose is deceptively simple. It objectively tracks your movement patterns.
How does tracking movement help diagnose insomnia?
Well, by tracking periods of activity versus inactivity, it can estimate your sleep-wake patterns pretty accurately over a longer period in your normal environment. It helps determine how much time you're actually sleeping versus how much time you are just lying there, awake in bed, which people often misjudge.
Okay, so it gives a more objective measure of sleep time versus time in bed. All right, so once you have a diagnosis, we need to talk treatment. You mentioned there's no definitive cure, but the goal is significant improvement and coping. Right.
Exactly. Management and improvement.
And the first focus is always maximizing sleep hygiene.
Yes, absolutely. Before anything else. That means things like trying to maintain a consistent sleep-wake schedule, even on weekends, as much as possible. Making sure your bedroom is cool, dark, and quiet, optimizing the environment, getting regular exercise, but making sure you finish working out at least 5 hours before bed so you're not too revved up. And limiting heavy meals or too many liquids close to bedtime. Basic, but foundational.
Okay, the basics first. But if those hygiene fixes aren't enough,
Then we get to the heart of the most effective long-term solution. This is where cognitive behavioral therapy for insomnia, or CBT-I, comes in. It's consistently recommended before trying sleeping pills, because study after study shows it's more successful and much more sustainable in the long run.
okay, CBT-I. You mentioned pills are often just a short-term Band-Aid.
Yeah.
Why is CBT-I considered the gold standard? And how does it specifically target that anxiety cycle we talked about earlier?
Well, the core insight of CBT-I is that for many people, chronic insomnia becomes a kind of learned behavior. Your brain starts associating the bed and bedtime with wakefulness, frustration, anxiety, worry, and your body develops almost a performance anxiety around the act of trying to sleep.
It's like, oh no, I have to sleep now. What if I can't?
Exactly that loop. CBT-I uses practical techniques to help you break those negative thought patterns and associations. It helps you relearn how to sleep, essentially, by reestablishing a healthy sleep drive and reducing that anxiety. And the success rates are really impressive. Our sources show about 4 out of 5 people who complete a course of CBT-I will no longer struggle with chronic insomnia to the same degree.
4 out of 5. That's incredible, especially considering it's drug-free.
Yeah.
Tell us about some of these techniques. They sound a bit counterintuitive. I
Mhm.
love the idea you mentioned of actively leaving the bed if you can't sleep.
Right. That's stimulus control. The rule is pretty ironclad. The bed is only for two things, sleep and sex. That's it. If you find yourself lying awake for, say, 20 minutes or so, you don't watch the clock obsessively, but roughly. You must get up, leave the bedroom, do something quiet and relaxing in low light, like reading a dull book. You only return to bed when you feel genuinely sleepy again. This works powerfully over time to break that brain's association between the bedroom environment and feeling frustrated or anxious about being awake.
Okay, retraining the brain's association. Makes sense. What about intentionally limiting the time you spend in bed? That sounds like it would just make you even more tired, doesn't it?
It does sound counterintuitive. That's sleep restriction. With a therapist's guidance, you might initially restrict your time in bed to roughly the amount of time you're currently actually sleeping.
Yeah.
So if you're only sleeping 6 hours despite being in bed for 8, you might start by only allowing yourself 6 hours in bed. The goal is to create a mild state of sleep deprivation.
To make yourself sleepier.
Exactly. It builds up what sleep scientists call sleep drive or sleep pressure. This makes your sleep more consolidated and efficient during the time you are in bed. Then, as your sleep efficiency improves, meaning you're sleeping for most of the time you're in bed, the time allowed in bed is gradually increased.
Fascinating. Okay, and the last one, the most head-scratching one. The idea of lying there and actively trying not to sleep.
Yeah, that's paradoxical intention. It directly targets the performance anxiety. If you lie down and instead of thinking, I must fall asleep, you think, okay, I'm just going to lie here and try to remain passively awake. I'm not going to try to sleep. By removing that pressure, that effort, the anxiety often subsides, and paradoxically, you frequently find yourself drifting off more easily because you took the struggle out of it.
Wow. So different techniques targeting different aspects of the problem. The association,
Yeah.
sleep drive, the anxiety. So medication exists, we know that, but it really sounds like it plays a very minor, maybe temporary role in the overall solution.
Precisely. Medication definitely has a place, but it's usually best reserved for short-term use. We're talking prescription sedative hypnotics, things like the Z drugs, which target specific sleep receptors, or maybe the newer dual orexin receptor antagonists, or even just over-the-counter antihistamines that cause drowsiness. They're mainly meant for short-term relief, maybe during a period of acute stress, or perhaps as a temporary bridge while you start implementing the long-term behavioral solutions like CBT-I.
Because they don't fix the underlying issue.
Exactly. They don't address the root behavioral or cognitive problems driving the chronic insomnia, and they come with risks potential for dependency or habit formation, daytime grogginess, or cognitive impairment, especially in older adults. So really, think of them as a temporary tool, not the cure.
Okay, that really clarifies the hierarchy. Hygiene first, then CBT-I is the gold standard, with meds as a short-term option if needed. That brings us back then to our key takeaway for listeners. We all experience bad sleep sometimes. That's normal. But if you have persistent difficulty falling asleep, staying asleep, or waking too early, and it creates real daytime dysfunction, fatigue, irritability, trouble concentrating, happening 3 or more nights a week for 3 months or longer, that's chronic insomnia, and it really needs professional attention.
And please remember that critical insight we discussed. Insomnia is fundamentally about the quality and function related to your sleep, not just the duration. You could technically be getting 8 hours, but if it's broken, unrefreshing sleep that leaves you impaired the next day, it still counts. And untreated chronic sleep deprivation is genuinely serious business. It significantly raises your risk for long-term health problems like high blood pressure, heart issues, diabetes, depression. It increases your risk of accidents due to slower reaction times, and it significantly complicates the ability to manage other existing issues, like substance use disorders, for example. It affects everything.
Such an important point. It's not just about feeling tired. It has real health consequences.
Yeah.
So the final word for our listeners.
If this sounds like you, if your sleep difficulties are truly impacting your day-to-day quality of life, please don't just suffer through it.
Talk to your primary care physician, or maybe seek out a sleep specialist directly. Getting an objective assessment and exploring effective treatments like CBT-I could be the most important step you take this year to finally put those sleep-related concerns to rest. Thank you for joining us for the deep dive.